make you a little bit confused about the deep hypothermia circulatory arrest, and I would like to repeat it again. So I want to start from here. Here is the step of the deep hypothermia circulatory arrest. And the thing that I mentioned to you is RCP and ACP, which is the retrograde cerebral perfusion, right? And antegrade cerebral perfusions. You're gonna go deep in detail in the next tomorrow sessions. However, another thing that I have mentioned is that PS stat and alpha stat. So when we cool down, imagine that when we cool down the patients, the PCO2 from the bad gas, if you correct, if you put a temperature parameter in the bad gas machines, it's gonna report that PCO2 gonna drop down. In terms of PS stat, they're gonna read that results and adding CO2. CO2 in the system might be rising up. So the effect of CO2 is gonna increase. Increase the diameter of the vessels or vasodilation, right? So some believe that we no need to adding PCO2 at all because we have auto regulations. So the patient could be adapted by themselves, but some believe that this is the like unusual condition. You need to correct CO2 to help the patient. You could be giving CO2 to correct the bad gas. So that is why they believe in the different theory. That is not, it cannot say that is good or not. It depends on the setting. It depends on another factor that relate to the outcome and complication. So from the vasodilation and autoregulation disturb, it's gonna compare pros and cons between alpha stat and PS stat during the deep hypothermia circulatory arrest also. Okay, this is a concept that I want to talk about. All right. So today we're gonna move to the topic 2, which is about conservation technique in the cardiac surgery. So I think everyone can download the handout from the Moodle, right? Okay. Let's start from the Hippocrates. Said that there are 4 components in our body. So one of this is the blood, which is the if we have imbalance between among all of these components, it can be make us like unwell. So we need to balance everything like this. So today I would like to talk about a technique in the cardiac surgery that be used for preserve the blood and how to use how to avoid the blood transfusion as much as we can. So here is the history of the blood transfusions. In the early period, try to make it experiment in the dog, giving the blood from the other dog to the other dogs. So so this is the first experiment that they demonstrate to describe it's possible to use the blood from each other people. Next step, 200 years after that, we have first successful blood transfusion from human to treat postpartum hemorrhage. I mean, a deliver can be caused with many massive of blood loss. So after delivery, a patient may be hypovolemic shock, and the doctor giving the blood to preserve their circulation. And the first blood bank has established after that, about 100 years later. So the first blood bank in the United States. Okay. It's another picture that shows you about blood bank that is quite important, especially in the during the war. There's a lot of people are losing the blood. Okay. So why we do need blood? Because yeah, so we back to this equations again. So this relation shows you that the hemoglobin is play important role to carry the oxygen. So we know that this all about our body. Oxygen is needed for organ function. So if you have enough oxygen, that you mean you're gonna every organ gonna work well. So so to preserve that, the hemoglobin is the main factor, right? However, if we are the perfectionist, you need to concern how to preserve that kind of this cell, because the CPB can be make an adverse effect to the many organ and also many protein, especially for the hematologic response. So to remind you again, you may be familiar with this slide from the previous courses. The blood surface interface and also the everything that we do during the CPB gonna make any cell and any system change. To focus on this, it's gonna change to the coagulations pathway, platelet functions, and so on. Also, the red blood cells, white blood cells, and many cells have changed due to the procedure. And also, we have the hemodilution exchange in the plasma, right? Hypothermia also that we have talked yesterday. And any cardiac heavy change. So we need to preserve to reduce its risks from the CPB. Okay. Here is the summary from the event that may be triggered from CPB. And we have prime circuits to make a hemodilution, right? So if you prime the circuit, you're gonna dilute everything inside the plasma. So every cell can be gonna be reduced, right? And the function's gonna that is the unusual conditions. Another thing is that because the surgeon performing the surgery, so it may be takers or the breathing, right? A medication or medicines that are the drug that the patients get before and during surgeries. It may be affect to this kind of problem too, because some drug like platelet, anti-platelet or a anticoagulant that they get before by their condition is gonna be make an effect during CPB too. Also, the patient condition. I mean, some patients has a disease like anemia, or some regions that maybe they avoid to transfusions. It's maybe effect to our CPB plan, like Jehovah Witness, that they don't accept to receive the transfusion from each other. So this is to make our plan to preserve the hematologic functions as well as we can. So again, I would like to remind you about blood product that we take the blood. If we take fluid from our vessels, we're gonna separate into many layers from red blood cells to plasma. So here also, if you are people giving the donor to the people, so your blood gonna separate into four main component. Firstly is the red blood cells. Secondly is the plasma and platelet and cryoprecipitate. So here is the indication to use. Also, we use that during this cardiac surgery also. Right. However, the transfusion takes risk to the patients. There are two types of transfusion lists that respond for the recipient. It may be okay, so then immediately after you're giving the blood to the patient. Another thing is can be delayed. That means after surgery, the patient has some conditions change in the ICU because of you giving the blood. This is the two part. So the acute that we need to concern most is that the allergic reactions or anaphylactic response, because it's quite very serious conditions to the patients. Okay. From the previous guideline, okay, the transfusion is indicate that the hemoglobin level is lower 10, lower 6. So we need to maintain the patient's normal level, like in the woman, maybe 10 to 13. In the man, it may be higher than this, but for 6 to 10, you maybe need to consider considerations on this condition. But however, this is the old guideline, but some part of them is still usable. The guideline also mentions about how to improve the patient's outcome, which is the preserve the blood by using the blood conservation techniques, and also improve the patient's outcome, and also transfusion at least as we can. So this is the blood conservation concept. So here is the definitions. The team approach to surgical patient care that utilize largest drug technology and technique to enhance patients' own blood supply and decrease blood loss. So that means we need to recycle the blood for the patient, right? So to avoid to use each other blood from the donor. So how we are usually separate timelines, classify the timeline into 3 parts, right? This during our management in our case, right? So same as this case, you're gonna see the pre-operations. You need to review the patient's breathing history or breathing disorder. So also review about there are any anemia condition or not, or review about any drug that the patient get. Intra-operation, you need to avoid hemodilutions. So minimize hemodilution because we cannot deny the we cannot say that we do the hemodilutions because it is not good to use the whole blood to prime the circuit, right? So we need to optimize hemodilutions for the patients. This is a key point. Also, use of anti-fibrinolytic agents for some center, they prefer to use that. To also a new technologies invite minimal invasive that we're gonna have a lecture tomorrow. Minimal invasive can be also precepts, the patients. And also we can use another special machine called cell salvage or cell saver during the operation to recycle the blood for the patients. Post-operative precepts, because we have make hemodilutions, and we have the patients have lost the blood from the surgical procedure, so the patients maybe need the iron supplementations to preserve the blood functions of the blood, and also we need to correct the reasons of the blood loss in each case. So okay, again, to manage we need to protect unnecessary excessive transfusions. So this is a repeat of previous slide again. Okay. Here is the update guideline last 5 years. So the same preoperative. Identify of the patient at high risk or not, like anemia, like a cell component level testing, like platelet function, any other lab report that can be detected that is high risk or not. In the intraoperative, that is our direct role on direct responsibility on the procedure. Firstly, some recommend about to use the MIECC or minimal circuit of CPB. We're gonna talk about that tomorrow, because if we short the circuit, make a circuit short, right, it's gonna help to minimize the hemodilution. Okay, antigrade or retrograde autologous farming, this is the one of strategy that we're gonna talk today. So we're gonna use the patient's blood to priming the circuit, but how to do that? Okay. And the next thing is that to balance between heparin and protamine giving to the patient. And some says that normothermia as much as they can, because the normothermia and normal pH it can be preserved the cell functions. The hypothermia is not good for hematologic status, so we try to preserve the patients as warm surgeries. But you need to balance between beneficiaries of the hypothermia and also the normothermia. Okay. And prevention by the fibrinolysis agents, like using the transaminase acids, protein, and so on. This is to depend on the center and institutability to use that. But some recommend to use transaminase acids to preserve the blood function during the CPV. Also, the cell server that I had mentioned, and we're gonna talk in detail of the cell server today. So for the post-operative, I don't mention much, but you need to preserve everything work well to make sure that all the components don't drop down during the post-operative bleeding. So you need to preserve by using sometimes we need to transfusions. But if you preserve well in the preoperative and intraoperative, it may be help a lot for the post-operative bleeding. This diagram just example to show you ASS or a drug, and also the DAPT, which is a dual antiplatelet that's using for some people who suffer with the cardiovascular disease. So if there are some emergencies, they allow to use that. But if they have some time to think, to stop it, they're gonna delay, like or stop some drug before the patient go to the hospital. So it can be help for some elective case. Okay. So you need to remind some part, like what is the competencies, what is the how could I call it? Aspirin, yes, aspirin. This is affect to the blood and breathing during the surgery. So that this diagram just show you some recommend to use or stop the blood in each urgent and emergency case. Okay. This is the Badminton guideline, also the same guideline from the 2017. So the recommendations, so we can focus on the green line here, like limitation of the hemodilution. We gonna make a circuit shorter than usual, so it's gonna preserve the hemodilutions. Use of antifibrinolytic like transamin diacet inhibitor. Transfusions of the packed cells based on the clinical condition. Yes, so we have measured the hematocrit or hemoglobin level during the CTB, but we also need to do we also need to consider with the patient condition in that time too, because sometimes the hemoglobin level is maybe from the other factor, so we need to show the risk factor to the right reasons and cause that make the hemoglobin level drop. So this is more important than if you have some results, you give the blood or blood transfusions. That just might not help too much. Okay. Okay. The team approach is also important, but should be considered is the one of the some team prefer to do that. Aspirin gonna continue or not, like a previous slide, right? Cell salvage or cell saver, MUF or other filtration that we're gonna talk today. RAP, rap, I mean it's not a song. I mean the retrograde autologous priming should be considered to do that. Okay. Heparin level and protein level also one of important. Okay. I'm gonna start from the ABT or a autologous blood transfusion here. Okay. Okay, what is autologous blood transfusions? It is correct and reinfusions patient own blood or blood components. That means all the blood that's lost from the patient gonna reinfuse. So how? It might be correct before the operation the operating day. So pre-surgical auto blood donations, that means the patient's gonna go to blood bank and give and let the blood out and collect it into the bag and save that for him or her to use that in the surgical day. So it's like you save the money in the bank, right? So you save your blood in the bank, in the blood bank, and when you need to use that, you're gonna use your blood from the blood banks. However, there are some limitation because we have only some limit volume in our body, right? So some people just use just let blood out like 1 or 2 units. That's some complex operations. It's not enough. and also there are some limit for storage. So we just keep the bus store for patients in the limited unit and time. Another procedure that can be referred to can be referred to autologous blood transfusion is we use auto transfusion blood process washer or cell salvage or cell saver. So this is a special machine that's using during the operations. If the patients had a blood loss in the surgical field, you can suction this and using the normal saline or any solutions to wash the waste product, to wash any kind of the unusual element or any that debits, so on, and recycle that and give it back to the patients again. So it can be said the cell saver is a process to recycle the blood to giving the patients. All right, here is the definition of cell savers: recycling the blood that would otherwise be discarded. All right, so because we are perform our lecture online, so it's not good if you have no experience about this before. However, I try to show you as much as I can, and if we have a chance to work up on this, I'm gonna make another special class for you later when, I don't know, we're gonna ask when the COVID gonna like situation gonna allow us to do everything. However, for today, you need to know the principle of this. This is one example about the cell saver machine that you see is quite smaller than the Halang machine, right? So there are some reservoir and also the back here. If you see this circuit, the green one from here to here that you see, this is a saline and solutions to preserve the blood from the patients. Here is the suctions catheter. So with the saline and heparin, it's gonna be preserve the blood that we suctions from the patient and collect it in the reservoir here. So in this size of reservoir, inside the reservoir, the blood will be mixing with heparinized saline, right? So when we collect this until the optimal level or the higher level enough, we're gonna start the pump here or processor pump here. The pump will be move the blood inside the reservoir along with move the saline, normal saline, to wash the cells inside the pump here. And the pump shapes, it seems like the cone. When it spin or go rotations and move like a circle here, the element gonna drop in the bottom of the cone. So it's gonna separate the layer of the red blood cell element and also blood cell element in the bottom part, and in the top of the this cone gonna have a sunlight and the waste product. So the waste product gonna let out to the another bag. So after we wash enough by sunlight, this in this processor bowl or processor cone gonna contain only the packlet cell. So you're gonna move the packlet cell into the packlet cells back here. And now we're gonna use that to reinfill to the patients. Okay. All right, that is overall of the cell server. I'm gonna repeat it again in the next slide. So this technique that I said, it's gonna collect and reinfill the blood lost by the patient during surgeries. It has a lot of history about this. Okay, so the new machines can be also separate the blood component into only red blood cells, only platelet, only the plasma. It's a wonderful machine. However, it's the same principle to use the cell salvage. Here is the classical machine that you see. This is adjustment not here and adjustable not here, and there are the pump, there are the reservoir, and there are the back, and also the tube connect with the suction catheter. Yes. However, there are some pros and cons also. So the mainly disadvantage is that it's quite costly for some center, and also because we mix the blood with heparins. So inside the blood there are content with heparin nice sunlight. So as it may be also list of the heparin reactions. And also because there's another extra machine, it's because they contaminate, highly contaminates, and also the hemolysis from the blood pump movement. Electrolyte imbalance because you're washing by using the normal saline, right? So we need to observe this kind of blood vessels. So okay. But the main advantage that we need to we need to look at this, reduce of this transmission of infection, because it's useless the transfusions from the donor. So the risk of transmissions is quite reduced. No risk of ABO because it's the same blood group, because the patient use their own blood to reinfill to the patient. So the risk of ABO cause math is it could be said that almost 0%. All right, except for some Jehovah's Witness that I have mentioned in early. Jehovah's Witness people, they try to avoid. No, they do not accept to receive the blood from each other people. So to recycle blood for them is gonna be a day. reduce demand of yes, any reactions. And to treat the DPG or any component of the blood will not change because we have do the same the blood that circulates in their own body, right? Doesn't make sense. Doesn't make sense. Also, it can be held clotting factor and preserve the inflammatory response process. All right, because we have watched out any waste for that, any waste medications from the blood before we reinfiltrate the patient. So it can be said that it's going to be preserved inflammatory response also. So indication generally we use that in the complex surgeries. It's not only the cardiac surgery because as we know we are directly to contact with the blood, right? Because we have a Hala machine, we have a lot of the blood process procedure. It can be applied to another vascular surgery like aortic surgery, like dissection surgery, and aortic repair for the aortic aneurysms. This kind of the surgery is a high risk of the blood loss. So to preserve the blood loss, to recycle the blood cell server is a good choice for them. And also traumatic case like accident or anything else, we can use the cell server also. The bone surgery, like some centers use a lot in the orthopedic surgery also because some procedures quite complex and they try to avoid it, but transfusions and the cell server is a choice for them. Pediatric surgery, because we need to avoid some transfusions because it's quite sensitive for the baby, and to recycle their blood is maybe good for them, but we need to specify some machines because it's a perfect size for them to use cell server. Okay, contact indications. I would say the contact indications is that to avoid patient some procedure like high risk to contaminations from feces and anything else like urine or amniotic fluids. So it's mainly in some surgery that relate to the GI surgeries because it's quite high risk to contaminate. And some infections, high risk of infections, preoperative. So this is a contamination. Another important condition that we need to consider is that about CA people of some malignant tumor gonna invest to the cell server system. So if the surgeons accidentally suctions on the tumor cells into the cell server, it cannot washing the tumor cells. So if you reinfill that kind of cell to the patients, it's gonna invest it generally or global whole body. So it is not harmful for the patient. So to protect the spread of the tumor cells, we need to avoid this kind of procedure. Okay. So here is the component that I have talked about, the centrifugal bowl or a pump or centrifugal pump inside of here, and there are a bowl here. If it's spinning, go round and round, and it can be separated two parts of the fluid. In the bottom is some element like liver cell, and some tiny level of the pellet and the white blood cells, but most of them contain of the red blood cells. And above of this is a waste fluid and sunlight that we're gonna move from this kind of bag. So if we spin and mixing the blood that from the reservoir, it's gonna wash out. Okay. After wash out, we're gonna give it back to the reinfusion bag here to make sure that and we can prepare that and already to reinfuse to patients. So here is the good diagram to show you. Aspiration set or suction set is here, including the anticoagulant with saline, heparin and saline mixing in here to preserve the blood clot. The reservoir is there with the filter here to avoid some dead beat. Okay, centrifugal bowl here. Roller pump to dry the blood from the reservoir and also from the sunlight, and also it can be open and dry the blood to the refill back here. Vacuum regulation, because we're gonna connect this reservoir with the vacuum to make a suction from the patients. Sunlight wash here, and anticoagulant that's put in here, and reinfusion bag is here, and wedge bag is here. Okay, so the process from the reserve from the cell server is that you need to sections and filtrations, and then centrifugal pump gonna move and washing. So the waste product gonna separate and let it out, and the cell cells gonna give back to the reinfused bag. So here is the repeat the step again. All right, this is all that I think I had talked about in early. Okay, so from the patient, first step, the section from the patient, go to the reservoir here, mix the blood with anticoagulant, right? And filtrations inside this kind of reservoir is gonna be filtrations from the large clot and debris. Okay, centrifuge and washings. So the first process is that the clotting reservoir gonna blood from here gonna move to the processor bowl or centrifuge bowl and mix with the saline to wash out the debris and the waste product. And then if you see the previous slides, the waste is gonna be separated two layers, two part of the fluids. So the waste product can be separations now. So we move the waste product out, and inside of that gonna contain only the packed red cell. We're gonna move packed red cell in the next step. But inside of the waste product, as I told you, it's not only the waste. Sometimes it's include the white blood cells and platelet. We cannot separate the white blood cells and platelet much. Okay. Here is the packed red cell that we are collect from the previous step. Okay, so if we need to concerned about the quality of correction red blood cells, it depends on the volume that we use to wash, the volume of washing solution here, and the degree of concentrations achieved. I mean, the degree of it means the hematocrit that we receive from the patients. If the patient has high hematocrit, the output gonna be high also, right? The quality of blood before washing, I mean any contaminate or any other stuff, the sunlight mixings from the operative field or not, because if there are a lot of mixing or hemodilutions, is quite affect to the output also. So re-infuse is the final step. If you re-infuse this kind of recycle blood, it's gonna be giving the hematocrit back to the patient at least 50%. It's quite a lot. It helps patients a lot, right? However, it has a limited time to preserve, to storage this kind of the product. All right. So the warning is that here you need to avoid some contaminate or some agent that we don't need to suction back to the circuit. Also some fluid. Okay, so and the next thing is avoid the high vacuum use applied to the circuit to prevent the hemolysis, to prevent the stretchings on the red blood cells and cause hemolysis. And anticoagulant also that's used in appropriate ratio to mixing. This is a guideline. Okay, this is a guideline to adjust the heparin drop. Okay, I would say you need to imagine a lot of if you have a real setting, it's gonna help you. Okay, I will try to contact to the company to have a sales server, but I'm not guaranteed that's gonna be available for us or not. All right. Okay, here is the guideline for storage the blood product after we using the sales server. Okay. All right, I gonna show you some video that maybe help you to see the picture. Okay. อันนี้เห็นไหมครับเห็นค่ะโอเคเห็น YouTube เนาะโอเค So you can see this kind of machines. They're gonna show how to set up. This one is a receiver. So you can see the port that that's connected to the suction line, and also the ports in the yellow is gonna connect with the vacuum. So inside of the reservoir, you can see the filter, the black color here. Here is the vacuum line. There are vacuum machine inside of the main machines here. So next is the panel. All right. Okay. Open the cover. So you may see the roller pump here, and here is the another centrifugal pump or any motor that can be spin and separate the fluid part, the fluid into two parts. So in these machines, it might be not the same that we see in the slide. Okay. Okay, you can see now there are transitions back. Here is the waste back, and here is the bowl. That I say is not the same as in the slide, but it's the same principle. It's just move spin to separate two part of the fluid. Okay. The technicians hang the transfusion back here. To install the pump bowl, just put in here. It's quite automatically set up, and install the tube into the pump. There are three pumps. One move the blood from the reservoir. One move the blood to mixing with the saline or washing solutions, and one to move the blood back to the infusions back. Okay. Okay. Then connect everything together, like this one to the reservoir, this one to washing mesh, to washing solutions, and the waste product is here. You see. Okay, and start the pump. It's automatically from circuit, and pump gonna spin right here. Okay. So this is All right. All right. That is just example from the cell server setting, but for the process, it's quite difficult to explain. So I have the diagram in from my slide. So you're gonna connect with them using your imaginations, and so it may be helpful for you. But anyway, you need to know the principle of this to use indications, and also what is a process that we need to consider. All right. Any questions about cell server? If not, we're gonna move to the next. This is the cell server or cell server system. As I told you, compare with my slide and also the video, you're gonna see it's quite different process. So there are many kinds of cell server. Just for example, for you to see pros and cons of each technology that you see from the machine that you see from the video. It says a continuous auto transfusion system, or we can call the nickname CAS here. Okay. But some machine they do not use the centrifugal. They use another device as the membrane filtrate, the membrane or any material like sponges to collect the excessive fluid. So the one example that if you remember about Dr. Gore lecture previous course, I think you can see there are some. He has mentions about portable cell salvage to use as the auto transfusion. So inside of the bag is gonna contain with the spongy, and this kind of the spongy gonna remove the excessive fluid from the patient, from the sections of process. So it's gonna make it's gonna separate the cell part and fluid part, and prepare that to washing in the next process. So it's just for example. Right. So we have some idea about the cell server, and the next step is we're gonna go to the another principle that we use to preserve the patient blood. We call filtrations. In the early, we use the washing solution, right? The next concept is that we let the excessive out by using the filtrations. How? Imagine that in the renal failure patients, they need to make a hemolysis in every week. That is one of example for out of filtrations process for the patient. So we need the material called filter or hemolyzer or something like that to separate the blood and the fluids, excessive fluid out from the circulations. So this one is the example for the filtered process. So we're gonna start from the term of the this kind of process. Firstly, hemoconcentrations. We have the membrane to contain the blood and remove the plasma out. But it's higher effective more than the hemofiltrations. So here is different kind of the. I mean it's quite make you confused, but some of that is just only conviction or not, like only filtered or not, something like that. It's just under a diffusion or a conviction or not. You're gonna see in the detail. But the main term that you may be see a lot is that hemodialysis or hemolysis, hemodialyzer or dialysis, something like that. Dialysis, imagine is quite related to the patients who suffer with the renal conditions, like renal failure or something, or any kind of that I explained you in early. If you combine between the hemofiltrations and hemodialysis, it's gonna be hemodialysis. That means you have both convections and also diffusions, right? Okay. For our aims, we can apply out of filtrations. That means filtrations a lot during CPB process. Okay. So we're gonna focus on out of filtrations. So the process is that remove unwanted excessive non-cellular plasma water and anything substance out from the main circulation fluid. So we need the device, and we try to use in appropriate case. Okay. Here is a symbol for a device that's using for the instant other filtrations. So inside of this, that you can see there are hollow fiber and a membrane here. Okay, so there are different sizes of this kind of the device. Also, the filtration system can be separated into many kinds of the system. Hemodialysis in early definitions and also dialysis. Okay, during CPB, we can do that by continuous. So we can call the continuous filtrations or conventional filtrations. Other nicknames is CUF or CUF. Another thing we have learned about we're gonna learn about cell washing, or how we use an filtration and washing at the same time. Okay. And the hemodialysis filtrations, that means we use dialysis or to in the same times of the filtrations. And of course, CPB, we can do the modified filtrations after the CPB. Okay. So why using the hemofiltrations? Because of we need to reduce total body water to increase hematokits and to reducing the blood transfusions. And it also removes toxic substance to reduce cytokine, to reduce any bad substance. So so if you see here, is there are substance can be classified into different size, as a large, middle, and small. So we need to preserve some substance, and we need to move out some substance also. So indication for making the autofiltration is that for some renal insufficiency patients in the cardiac disease, so imagine if the patient undergoing the cardiac surgery, if the patient has the underlying of this kind of disease, the renal do not work well to let the fluid out by urine output. So we're gonna help this kind of people by using another. It can be said that this is the artificial kidney also. So we use autofiltration as an artificial kidney to preserve the these patients. Okay, for some procedure like trauma or any blood loss before going to the cardiac surgeries, the patient may receive some extra fluids to preserve the hypovolemic shock or anything else. So fluid overload or fluid retentions gonna remain inside the patient. So interfiltration is gonna be held in this kind of issue. All right. Also, it can be helpful for the hemodilution in during the procedure. So if there are a lot of excessive fluids, it can be let it out. Okay. And some studies says that it can be preserved the EF and high Euro score, but not confirmed about this because there are many factors. But just some said that it can be helpful for let some mediator out, and it can be like bad mediator to trauma to make the patient's worse conditions. So it can be helpful for preserve the high risk patients. So how we connect the conventional? Okay, I would like to start from the cup first, and how we connect the filter to the circuit. So there are two types of the cup, which is the AV cup and VV cup. AV cup, that means you separate the blood from the arterial size. That means after the pump to the hemofilter here by using another line. And this kind of device gonna filter the blood, and you can let the waste product out here and give it back to the patients where the venous reservoir. Here is the another picture. So in this picture that you see, they connect the filter from the plug line of the arterial line filter here and go to the filter here, right? And go back to the reservoir. So here is the waste product gonna let out from here delay. Okay. So during this procedure, during the LV cuff, the main pump or arterial pump gonna move as the normal. So everything just recirculation pass through the filter like this. But another kind of the conventional filtrations we call VV cuff, or from the venous to the venous side. So it's quite different. It's quite no, it's just only point that different from the AV cuff. So from this, imagine that you put the separate line or this line after the pump flow. So inside of this, there are a lot of there are a high pressure flow, blood flow, right? So you just put this without using another extra pump. But in the VV cuff, we put the cuff line from the venous side, like in this picture. In this diagram, they separate the blood directly from the reservoir. So it needs another pump to drive the blood go through the hemofilter. So here is the different point in the AV cup and VV cup. VV cup need the pump, extra pump, but AV cup do not need the extra pump. So the pros and con is that if we use another pump, it may be make more high risk to the hemolysis from the blood from the raw pump, and it's more costly. But it do not disturb the main pump flow. I mean, it can be individual control, right? But it's in this kind of the cup or AV cup, the arterial pump payroll as the maintain the main CPB circuit, and also maintain the flow to the hemofilters too. So it maybe need a little bit increase to preserve the flow that lost to this extra circuit. All right. Okay, what we need to concern from the cup firstly, because we have separate the volume, so we need to make sure that we have enough volume in the circuit and the system. Okay. And as I have told you, we have make a shunt or extra circuit from the main circuit, so it can be separated blood flow, and we need to increase the we need to stop this shunt when we are winning the CPB, because it's deterred to the blood support to the patients. Also, to safety, we need to put the level detector to the reservoir. And we need to use appropriate cup process, because if we filter a lot, maybe in adequate volume in the reservoir, especially for during the weaning that we give back the blood to the patient. If we have not enough volume in the venous reservoir, we're gonna give another saline inside the reservoir again. So that is not help us, right? So we need to optimize this process during using in the CPB. Okay. All right. Another term called buff or balance interfiltrations or zero balance out of filtrations. It's we said in another name like a CURT here, C buff, buff or H buff, and DUF is depend on the hospital. So the main concept is that some people who have the condition, like some people they have renal conditions and they cannot eliminate the potassium by native renal themselves. So the potassium is in the blood gonna get higher, especially for after we giving the cardiopegia. So if the patient has hyper potassium, it's gonna be cause a worse condition. So to do that, some people put the normal saline. The normal saline is, we know, it not contain the potassium to dilute the potassium in the system. All right. However, if we put another replacement or a normal saline into the CPB circuit, it's gonna be make a hemodilution, right? So to avoid the hemodilution effects, we're gonna remove or out of filter this kind of excessive fluid out, and the potassium that contained in the circuit, contained in the circulations, it's gonna move out along with the fluid that we filtered out. All right. Okay. It's also used to remove another unnecessary small molecule content also. The next procedure that might be useful for you is called a MUF. Here is the modify outer filtration process. Both CUF and CBUF they use during the CPB, but the MUF is used after we stop the pump. Before we start the protamine synthase, some team prefer to use the MUF to filter again to let the excessive fluid out. So here is the example of the AV MUF. Imagine that we have stopped the pump, right? So we can now connect another circuit into the patients. So this kind of circuit gonna connect the another line to the hemofilter here and go back to the HVC or IVC catheter or cannula. So during this procedure, the AV MUF the blood go directly from the arterial side, go to the filter and go back to the venous side where the venous cannula, right? However, during this time, we need to preserve the blood flow by still adjust the arterial flow also to compensate the flow to avoid the blood drop, BP drop, and air in the arterial line. So the MUF flow can be adjusted to here late. It's quite different for the adult and pediatric. And how long that we move the MUF? We do the MUF. Some people prefer to use that 10 minutes. I mean, okay, imagine that you have a MUF, right? You prefer to do the MUF, right? It seems like another extra time for CPB. So you have another extra time, 10 minutes to process the MUF. So like a half MUF have another setting called VV MUF. So here is the setting for the VV MUF. Okay. All right. You use high imaginations, so I do not expect that you understand most of them, but the most important thing that you need to know is you need to understand what is the principle of that. So here is the MUF diagram. So maybe the same previous one, but I took it from the this one from the textbook. So so you can see AV MUF and VV MUF is separate procedure. So when you read this slide, you're gonna keep in mind that it's a separate procedure. So here is the thing that we need to concern to do the MUF. Okay, all right. We have another extra time. So before we giving the protamine to reverse the heparin effects, it's gonna be delay. All right. And because we have another system, so the air entrapment into the MAF system should be awareness because it can be occur. So to compensate that, we should run both the arterial pump and also the MAF pump together and compensate this and to preserve the mean arterial pressure and also to avoid the blood to avoid the bubble occur inside the circuit. All right, it is the lead that used and also everything. Okay, the MAF take over the benefits of cough and CPAP because it can be let the heal molecular size mediator like inflammatory or cytokine protein. So it can be said that the MAF can be held to preserve the inflammatory response from this CPB. Here is the support study that they study about how to use the MAF to and they measure the inflammatory response after that. It's helpful for the patients who has high risk, like in the small people, like neonatal and or pediatric cases. That is most of the center in Thailand and the worldwide centers prefer a lot to use MAF in the pediatric case. And also some center prefer to use that in the complex adult case like prolonged surgery. Because if we have a prolonged CPB, imagine that the cell has make a high response of inflammations, right? So to help the people, the MAP could be a one of the best choice. Okay, any questions about BAP and MAF? Cup, BAP and MAF? Any question? ยังอยู่ไหมเนี่ย
ยังอยู่ค่ะ
Okay, alright ถ้าไม่มีคำถามก็ตอบหน่อยจะได้รู้โอเค alright if not we're gonna move to the next step. Okay, we have mentioned about the renal disease people. So here is another procedure which is an option. Okay, so just that we already have a hemofilter, right? So why not we put the dialysate or a dialysate solution inside the into the circuit. So now it's much more effective to let the waste product out, like people who has a dialysis. Right. So here is the example for the setting for the hemodilatation. Okay, but before you use that, you need to consult with the nephrologists, the physicians who expect in the field, and you need to you need to make a monitor to the patient much more than each other because it's quite huge effect to the patients. Okay. All right, here is the outcome filtration. The last sessions of this lecture is the retrograde autologous farming. So retrograde autologous farming, the name of autologous farming, we know autologous mean itself or patient cells. The patient's blood gonna farming by retrograde way. Okay, so from this diagram, okay, we're gonna start from the main diagram first. From the patient, go to the venous cannula, go to the venous reservoir, go to the arterial pump, heat exchanger, oxygenator, go back to the patient by arterial line. Before we start the procedure, before we start the CPB, the surgeon's gonna perform the arterial cannulation live. So after arterial cannulations, now the CPB circuit connect to the patients. If we just cramp here between arterial filter and between the venous line and let the blood move out from the aorta to the arterial cannula to the arterial filter and go back to the venous reservoir, it's gonna be slowly replace of the whole priming solutions until we happy with the retrograde blood move back to the reservoir. We're gonna have another priming solution. So we can let the previous solution out and collect it in another bag. All right. So to clear more or make you confuse more, I'm not sure. Here is the same thing. So now we have arterial line here, right? And here is arterial filter. And here is a pump. So from the patients, from the arterial filter, when the surgeon connect the cannula to the patient, we just open this line, and the blood gonna replace this one and push the priming solution go to the back or go to the bridge here, and when the sunlight or the priming solution go to here, we can let it out and keep only the blood inside the line. Also, in another side, we can separate that from the perk line into the reservoir and prime this kind of this part of the circuit also. And another side, I mean the Venus line, we also open the line after our Venus cannulations and collect the primary solution inside the collecting bag here. And the whole circuit will be contain only the autologous bus from the patients. So that's the procedure that we call the RAP. Right. Okay, I have some video to show you. So we have now the collecting blood here, and here is the arterial line. The yellow might be farming solutions. So we have a cramp on venous line here. We have a cramp on the collecting bag here. We can make a bridge before the clamp from here to the manifold, and manifold gonna control the blood directions. Okay, here is the main pump. So now we do not start the pump at all. After cannulation, we're gonna release some cramp. Okay. So now that you see, we release cam on the arterial line and collecting blood, and we open the T-way here, and we expect that the blood gonna move from the patient go to the collecting bag that you see, but it's go slowly fill up the circuit, and the collecting bag gonna light things up. So now it's already repressed the fluid until about here, and the next step, we're gonna prepare fluid from the venous side. So we're gonna open the venous line, and the blood gonna move to fill this line until it's moved to the reservoir, and until we happy to collect the blood. In this time, you might be flow the pump slowly to drive the blood, to drive the priming solution into the collection bag here. So you can see the collection bag gonna contain only the priming solution that we are pumping in early, and the whole system is gonna be contain the patient's blood, or this kind of procedure called the retrograde autologous pumping. Okay, any questions about that? Oh my God, I'm a good teacher. Okay, the next procedure is called Electron Fusions. All right. A direct transfusion is the process that we use to collect the blood or use the blood that from the reservoir after we finish the procedure or we stop of CPB. Imagine after we of CPB, some fluids still content in the circuit, right? It's still filled in the circuit. We can use that kind of the blood infill back to the patients. But imagine but that kind of blood is a dilution because it's forming in the circuit, and also it is the heparinized blood. So be careful to use the direction transfusion from the extracorporeal circulations. Okay. A suggestions here is all about the today lecture. And any questions? มีคำถามไหมครับ
อาจารย์ค่ะ
ครับ
อันที่เป็นแรปอะค่ะอาจารย์อธิบายอีกรอบหนึ่งได้ไหมคะแต่เป็นแบบกระชับก็ได้ค่ะอาจารย์
โอเค
ค่ะขอบคุณค่ะ
ขอบคุณที่มีคำถามครับ Okay, wrap is the autologous priming. So if you see from this slide, compare with the video, it's quite a little bit different, but the same principle is that using the autologous priming to prime the circuit to take place the previous priming solution. Okay, how could I say? Imagine that we are okay. We use another imagination part. Imagine that we have set up, connect all the circuit together. After that, we need to load some solution to prime the circuit, right? But that kind of solution is only wrinkle solutions, only slide, only the priming solution that we have talked in early course. So some center they found that to use that kind of solution, it's gonna be make a huge hemodilution effect. To help that, they think why not we use the patient's blood to prime the circuit. So the procedure starts from that kind of philosophy. Okay, after we priming the circuit by the clear solutions, we're gonna apply we're gonna replace that solution and let that clear fluid out from the circuit. So how? After the patient have cannulations, that means we connect the circuit with the patient, right? So we can let the blood from the patient, and that's kind of blood gonna slowly replace of the clear fluid that we are priming in early. Okay, that is the concept. So to make it easy, I think this is quite clear for for the step of the lab. Imagine that this side is the Venus line, and Venus is gonna connect with the SVC IVC cannula, and another side is gonna connect with the arterial cannula. We're gonna start from clamping on here, I mean Venus line and arterial line here, and clamp on the collecting bag. This bag gonna takes a responsibility on the collect the clear solution that we have from in the initial state of the setting. So how to replace the blood from the patients? After the surgeon do the arterial cannulations, we can slowly open this clamp, and the patient blood gonna move automatically from the patients and take place the fluid inside the tube. Okay, take it off board, and the fluid gonna go from here to here, right? And clamp. And if you see, we just have only this red color. Another side we can do also the same for here. Okay, now we open the clamp here. The fluid is gonna move from the tube to the reservoir, and to help that, we're gonna move move the flow a little bit to move the clear fluid from the reservoir back to the collecting back here. All right, so now we are all ready to run on the pump. So in the circuits contain only the blood, pump the blood from the patients. So why they call us RAP? Why they call retrograde? Because in the early they open their arterial line here, and it is the retrograde way against from the blood pump direction. It's called a retrograde orthogonal pumping. Okay, does it clear or not, or make you more confused?
เคลียร์ค่ะอาจารย์พอครั้งที่ 2แล้วโอเคขึ้นค่ะ
ครับ
ค่ะ
Thank you so much for your questions. Okay, any question? So I have a suggestions lecture on the YouTube. If you have some time to look at that, I recommend you to it's a short lecture. It's about half hour. It maybe help you to more understand. I'm not confident in my lecture much, but to help you, I recommend to attend this one. And so anyway, if you have no another questions, we can leave by early now. But if you have any question, you can leave direct message to me. Okay. มีคำถามอีกไหมครับ Okay, that's it all for today, and I hope you have a good day. And don't forget the lecture tomorrow. I expect that I need your response to our guest lecturer. Okay, we have 2 guest lecturer from Sirius Hospital and also the Bangkok Hospital. All right, see you tomorrow.
Thank you อาจารย์
ขอบคุณค่ะ
ขอบคุณค่ะ